One. Sir, please start.
Good evening, friends. Welcome to the Thursday evening webinar series on the PG track program. In the 43rd webinar today, we are going to discuss the hemodynamics of constrictive and restrictive physiology. It is one of the very important and subjects which is often asked in theory exam, also as in the practical exams, and also for the practical clinical understanding. And we have had a previous lecture, but today we are going to have a very practical physiological classroom teaching by Dr. Saurabh Gupta. On this journey, I have with me my colleagues, Professor Samod Kurian, Professor of Cardiology, Dr. Safal, Associate Professor of Cardiology, and myself and my colleague, Dr. Girish MP, are there. So over to you, Sumod, to welcome our very dear friend, Dr. Saurabh, one of the great speakers. And if you have any questions and comments, please feel free to write to us any clarifications you want regarding the same topic. Please write to us in the chat box. We'll be very happy to answer back all the queries. So over to Dr. Sumod to please start the session.
Yeah, once again, a very warm welcome to today's PG Track session. As Dr. Mohit has already told, pericarditis and constrictive physiology is one of the common short case. So Dr. Saurabh is a very good teacher. He's the additional professor at All India Institute of Medical Sciences, and we welcome Dr. Saurabh. Please come and tell us about the common and important aspects of constrictive pericarditis and restrictive physiology. Welcome, Saurabh.
Thank you, Dr. Sumod, and thank you, Dr. Mohit and others for allowing me to share my thoughts. And I'm generally quite happy and a person who look forward to postgraduates, because I feel this is a time spent well, because once we spend time on the next generation, we are going to have a better critical mass for the future academics in cardiology. So without taking much time, I'll go on to say that those who are listening, this might be somewhat repetitive, but I will try to take a different perspective to hemodynamics of restrictive and constrictive physiology. And I'll start not from the disease itself. I'll rather start from what we understand as normal physiology. And in the process, we will try and understand how, why, and what of constrictive and restrictive physiology. Now, if you don't understand the basics, it becomes a fact. While if you understand the basics, it becomes a concept. So I will try and give some concepts rather than giving you some facts, because facts you have already would have read in books, you would have heard in some other presentations or maybe some articles. So let's try and go to the basics a bit. So the human heart and circulation is quite unique in the sense that it is a circulation in series where the venous system, the systemic venous system, is connected to the systemic arterial system or the oxygenated system via lungs, and this is called circulation in series. And if you see this diagram, there are two trains which are going around each other, and that's how we get near normal oxygenation, which is quite unique to mammals later in the evolution. Now, this is how we teach, or we initially understand how the heart beats. And as we can see here, atriums are contracting. And then if you see carefully, even this mitral valve seems to have opening twice during its opening phase. And that practically summarizes how the blood flows from atriums to the ventricles. And as I said, right atrium gives to the right ventricle, and then it goes to the pulmonary artery to lungs, and then comes back onto the left side. And if I say that this animated GIF is not completely correct, possibly some of you will say, what is wrong in that? And it perfectly shows everything what needs to be shown. But I'll tell you what is not so clear in this. And that actually determines how well we will understand our constrictive physiology. Now, this is vigorous cardiac cycle, and we all have read in our physiology, maybe while we were preparing for our cardiology, but possibly not later on, but it remains one of the most important thing or concept to understand. And as you can see, most of the diagrams focuses more on the systole, while what we are going to discuss today is the diastole. So this was the left heart and this is the right heart. And as you can see here, these are the various heart sounds which will coincide with different pressure changes in the left and the right side. But as I said, most of the diagrams focus on the systole because we tend to think that systolic function of the heart is much, much more important than the diastolic function, but that's not true. And we are having more and more evidence to suggest that diastolic function is equally important, if not more. So this diastolic filling phase can be divided into 4 parts. This is one, isovolumetric relaxation, rapid filling, diastasis, and atrial systole. So these two, this atrial systole and rapid inflow, these are the two ones which were opening the mitral valves twice in during ventricular filling, and that's what was seen in that animated diagram. Now, if you zoom it up further, then this is what diastole we need to know. So this is the intraventricular, isovolumetric relaxation time. This is the period of rapid filling. And as you can see over here, this is the time of V wave. So the V wave will actually will be bisected by the descent of LV trace. This is the dip diastolic pressure, or sometimes it is called as minimum diastolic or ventricular pressure. Then there is equalization in between, which is the period of diastasis. And later on, during atrial contraction, there is again a rapid filling phase, which is like coincides with the A wave. And this is the point where we generally take the LVED. Now, the lower line diagram shows how the mitral flow occurs in a normal person. And as you can see, this phase contributes to 0% mitral inflow. Rapid filling contributes to almost 3/4 of the mitral inflow, and rest happens during atrial contraction, and diastasis contributes to less than 5%. And this is important because this is what determines in which restrictive physiology what all will happen. Now, this is what we understand in terms of echo. If we see, so this is the RT, this is E wave or the rapid LV filling, this is the diastasis, and this is atrial contraction. And by this synchronized filling of ventricle from the atriums, what happens is all the pressures are connected. If you see from the left side, the LVED is connected to the LA mean, or more precisely, LV mean pressure is connected to the LA mean, which is equivalent to pulmonary artery wedge pressure, which is equivalent to pulmonary artery diastolic pressure. And that's how the whole system is connected to each other if there is no obstruction in between. And these things are important because these changes, if there are changes in the LV myocardium or pericardium, changes will be reflected onto these pressures, and these forms the basic of why these changes happen in any particular patient. Now, till now, we have seen how pressures are generated, how blood is flowing, but a fundamental concept is still missing. And what is that? It is respirophasic variation. If we don't understand that, we will not be able to understand what happens during constriction. And that is why it is important that we understand what happens with inspiration and expiration. So during inspiration, what happens is there is a negative intrathoracic pressure. Blood flows more into the right ventricle, and therefore the right ventricular systolic pressure is higher compared to left ventricular systolic pressure. During expiration, the reverse happens, but this difference is less than 10 millimeter of mercury. So what we are seeing here is actually respirophasic variation. But since it is less than the clinical levels, we don't mind that it exists. But when it becomes more, then we start thinking that something else is happening. And that is possibly what we are looking at today to understand. We also must understand that pulmonary veins and the posterior wall of left atrium lie outside the pericardium, while rest of the heart is within the pericardium. So whatever changes are going to happen because of pericardium will not be there on the pulmonary veins and the posterior wall of LA, and it will have significant impact on how different pressures will occur in constrictive physiology, and that is why we need to understand this. Now, this is a little offbeat, but if we need to understand the physiology of any restriction or constriction, it is mandatory that we understand what are the relationships of left ventricle and right ventricle, how does interventricular septum contributes to ventricular contractility, and what happens to the cardiopulmonary interaction. And so this chapter is from Mawson and Adams. Those who are interested can go and read. It improves the understanding quite a lot. As you can see over here, RV workforce is like a trapezoid, while LV is much more. So intuitively, although both are giving rise to same stroke volume and the cardiac output, the RV work is much lesser than the LV work. And as I said, this is a little offbeat, not related to this, but if somebody wants to understand the physiology properly, this chapter is probably a must to read. Now, in this one, what they did was they paced the left component of the LV, and they could generate a good RV pressure without even pacing the RV. So it is to say that LV provides good enough contraction and pressure onto the right side, and the right ventricle also contributes to contractility on the left side. IVS plays an important role, and IVS is part of both RV as well as LV, and this interplay of right ventricle and left ventricle determines how different chambers will be working in sync or out of sync. Now, how blood flows from left ventricle or lungs to the heart is, it depends upon what is the pressure in the pulmonary capillary wedge, what is the pressure in the pericardium, and what is the pressure in the intrathoracic region. If the intrapericardial pressure increases, as you can see over here, your effective filling pressure is going to come down. And this determines how, even with the increase in the wedge pressure, whether or not left ventricle will fill in a given patient. So this is what I was telling. During inspiration, RV is filled more, the septum bulges towards left, and the reverse happens during expiration. And in a way, the pericardium is surrounds right ventricle and left ventricle, and it allows or facilitates this interaction between two ventricles to augment the contractility of both of these ventricles. Now, let me take one case scenario. So this is 25-year-old male, hemoglobin 13 gram, VO2 131 with a SVC saturation of 52. And this patient presented with heart failure. If you see these pressures, I think immediately you will realize that the SVC saturation is low. So the patient is having low cardiac output, and the diastolic pressures are all elevated, and they are in the same range. We will evaluate this patient in the coming slides, and we'll interpret it later on. So the question is, what are the different characteristics in this hemodynamic data set which tells us which kind of disease we are dealing with? So now the question is it constriction or restriction? So as I sometimes say, confusion is the first step towards clarity. And if we are confused, it's actually a good sign, because that means that our gray cells are stimulated and we'll be finding something good. So if you search on internet constriction, actually constriction is a method used by various snake species to kill or subdue their prey. And once we understand this, then we will understand what do we mean by constriction physiology. This is also explained in this simple sentence, which says, the snake coiled around his torso, constricting his chest. This in turn restricted his breathing. So constriction ultimately leads to restriction in the filling. Constrictive physiology is type of restrictive physiology. These are two different physiologies because of their unique characteristics, but both can be clubbed together into restrictive physiology. So if we say all constrictive physiology patients have restrictive physiology, but not all restrictive physiology patients will have constrictive physiology. And that is why we need to differentiate between the two. Now, if we see more dramatically, then what is constriction is something like this: a thick skin like here, and restriction is something like thick myocardium or the heart muscles. If you see another diagram, restriction, I'm sorry, this should be reversed here. Constriction is the thickened layer outside the heart, while the heart cavity is not thickened. While in the restriction, the heart cavity or the chambers are thickened, while the outer pericardium is thin and it is not thick. Now, generally speaking, pericardium is protective, but if it becomes overprotective, we all know too thick walls are not good either. And what happens if the pericardial thickness increases? Then what happens is the cardiac volume determines how much heart can move, how much left ventricle can push the right ventricle, or vice versa. This restriction occurs in mid to late diastole, and the ventricle fills in early diastole. So maximum filling occurs during early diastole, and it is further exaggerated compared to a normal person. End diastolic pressure in all chambers are equivalent to pericardial pressure, and being low pressure, the right heart chambers are more affected in this physiology. Now, let us assume this is the pericardium, which is supposed to be protective. What happens if it becomes thick? It actually reduces the volume available to the ventricles, and that is how this overprotection becomes a kind of harmful thing for the heart and the hemodynamics. Now, how does blood flow in pericardial constriction? As I said, the majority of the filling happens during early diastole, which is actually which actually happens in the normal case also, but here it would be much more. So if in the normal person it was 70 to 80%, in pericardial constriction it would be say 80 to 90%, and rest of the phases it will be just minimal. And this will have bearing on all the hemodynamic things which we are going to see in coming slides. Now, what other thing happened during a pericardial constriction is that this thickened pericardium doesn't allow the transmission of thoracic pressure onto intracardiac chambers. So what happens is during inspiration, when the thoracic pressure is negative, normally intracardiac pressure also goes negative, and that facilitates filling. But in pericardial constriction, that doesn't happen, and we will see changes because of this. So there is discordance between changes in the thoracic pressure and intracardiac pressure. Something else happens. During inspiration, what happens? There is reduction in pulmonary capillary wedge pressure. There is no change in LV EDP. So what happens? The reduced LV filling happens. Now, if you notice here, the pulmonary capillary wedge pressure is reducing, but the cardiac pressures are not reducing. That is what I was meaning when I was saying that the intrathoracic pressures are not reflected onto cardiac pressures. And therefore, what happens is inspiration has preferentially RV filling, and the reverse happens during expiration. So to summarize, inelastic thickened pericardium with reduced compliance will lead to fixed pericardial volume and mid-diastolic restriction, which fails to accommodate increase in the venous return. In addition, there is dissociation of thoracic and cardiac pressures, and these two leads to exaggerated ventricular interdependence, which is the hallmark of pericardial constriction. So as a result of these two things, what happens is pericardium actually puts RV against LV, and they both fight with each other for preload. When one is getting more preload, the other is depleted of the preload. Like in inspiration, RV is getting more preload, but the LV is getting less preload, and the reverse happens during expiration. And that is what we are always saying, ventricular interdependence. So as we saw earlier, ventricular interdependence is a normal phenomenon. But here, because the pericardium is kind of playing a game against both LV and RV, this ventricular interdependence is getting exaggerated. So if we say that this relationship is like strained yin and yang, RV and LV are yin and yang of cardiovascular flow and hemodynamics. And what happens is, because of this issue of thickened pericardium, the yin and yang relationship is strained. And that is why we see a lot of clinical and hemodynamic manifestations in pericardial constriction. On the other hand, in restriction, what happens is, it is like this double-walled cup where the walls are thick. So they are not allowing it to flow. There is nobody else outside. So the problem is lying within the myocardium. In the constrictive physiology, it is lying outside the myocardium, and pericardium is kind of playing a game with LV and RV. Here, LV myocardium itself is at a fault, and that is what it limits the diastolic filling. Now, let's go to stepwise analysis of hemodynamics. So first we look at systemic veins in right atrium because they are connected to each other. Then we will look at right ventricle and left ventricle. Then we will look at what happens to capillary wedge and left ventricle. So now this is jugular venous pulse. And as we just discussed, that majority of the filling is going to happen here. So if it happens here, then this coincides with this area. And that is why we find rapid Y descent, what is also called as Frederick's sign. And this is how we will see the M pattern of the JVP. Okay. On the other hand, in RCM, the flow is also happening here, but it is restricted because of the myocardial problem. So the Y is still there, but X is blunted there. So that is the difference we will find in jugular pressure. If we see the RA trace here, this is the trace in constrictive pericarditis, and this is the trace in restrictive. If you can see here, there is no ECG, so it becomes slightly difficult to see which one is what, but this is from a literature, and I will tell you which article is this, so that you can go and read. So this tells us why these two traces are different. As you can see over here, the diastolic pressures are different in these two conditions, and Y descent is prominent in both, but the X is more prominent in constrictive physiology, and it's not so much in restrictive physiology. If we look at the right atrial pressure, this is the Y descent and this is the X descent. Another thing which is prominent in right atrial pressure is that it varies very little with the respiration. And why it is so? Because right atrium lies within the pericardium. The wedge pressure continues to vary with the respiration. Why? Because wedge pressure and the pulmonary veins are part of extrapericardial space. So there is a discordance between right atrial pressure and wedge pressure. RA pressure doesn't change with respiration. Wedge pressure will continue to show variation with respiration. Now, there's something called Kussmaul sign we keep discussing. Inspiratory rise in right atrial pressure or inability to fall in right atrial pressure. This is not unique to pericardial constriction. And if you go back and see this trace, you will realize if the patient is having inspiratory increase in this flow, but the right ventricle has limited capability to accept that flow because the pericardium is there to stop that. What happens? The flow increases or the JVP increases during inspiration, and that is what is Kussmaul sign. On the other hand, in the in restrictive cardiomyopathy, what happens is during inspiration, patients' RV inflow has to increase because there is negative intrathoracic pressure, but RV myocardium is not allowing blood to flow in, and therefore there is also Kussmaul sign which is positive. So Kussmaul sign is positive in both restrictive as well as constrictive physiology. Reasons are different. In one, it is the myocardium which is stopping. In the other, it is the pericardial volume which is stopping the blood to flow. I mean, there are various theories which are given for Kussmaul sign. Those who are interested can read in that, but important thing is that it is common in both the conditions. Now, if you go to other systemic veins, now you just think over what happens during constriction. During expiration, blood is preferentially going to the left ventricle. The right ventricle is having less volume available to accommodate that blood. So what happens? It shows up as a reversal during expiration in the hepatic veins as well as in the superior vena cava. On the other hand, in restriction, what is happening? In restriction, it is the myocardium which is stopping. So as and when there is increase in the flow, so like for example, these are all right-sided veins. So if the flow has to increase, it will increase only in inspiration. So you will get inspiratory flow reversal in restrictive cardiomyopathy, while it is expiratory flow reversal in constrictive physiology. So this is the example of restrictive physiology where during inspiration, because the myocardium is not able to accept that increase in the flow, it will cause reversal. Now coming to ventricular discordance or exaggerated ventricular interdependence. I mean, these are two same terms which we keep using interchangeably. But if you see over here, there are many things which we can read in this. So this is the RV trace. If we start telling the abnormalities, then what we can say is RV pressure is elevated, but it is below 50, which is one of the characteristics of constrictive physiology. It also has elevated end diastolic pressure, and the gap between the LV end diastolic and the RV end diastolic pressure is less than 4 millimeter of mercury. That is again a sign of constrictive physiology. There is a square root sign. I will come to that, but it says that there is a sharp dip followed by a plateau. That is again a sign of constrictive physiology, although it can be seen in other conditions. What else is obvious here is that during inspiration, the left ventricular pressure has reduced from nearly 90 to 80, while the right ventricular pressure has increased from 40 to 47, or maybe say 50. So this is what we call as respiratory variation or exaggerated ventricular interdependence or ventricular discordance. It means that the left ventricular pressure and the right ventricular pressure are out of sync. They are 180 degrees opposite to each other. When during inspiration, RV pressure is increasing, the LV pressure is reducing. And in restriction, what happens is during inspiration, what is happening? Myocardium is not allowing the blood to flow. So both the pressures are reduced. Even the RV pressure will reduce because there is no preload. So the pressure generation will be less. So the ventricular output will be in concordance in restrictive physiology. Now this ventricular interdependence or ventricular discordance is also seen in mitral and tricuspid valves. Now, first of all, we need to know how do you calculate that percent variation. So the percent variation is calculated by the value in expiration minus value in inspiration divided by expiration. So if you see mitral inflow, then it will be expiration minus inspiration divided by expiration. Now, since E is higher here, so this value will come in positive, while the opposite will happen on tricuspid side, and therefore this value will be in negative. So this is again a sign of exaggerated ventricular interdependence. Now this is septal bounce, very famous constrictive physiology sign. And as you can see over here, this is the respiratory variation, which is pushing the septum towards the left ventricle. And there will be different modalities in which you can see. If you are observant enough, you can even see on coronary angiogram, as I saw in one of the patients. And as you can see over here, when the patient take deep breathing, the septum bulges towards the left side, while when the patient when it is expiration, the septum bulges towards the right side. So there can be different ways you can find out septal bounce, but it all is reflective of exaggerated ventricular interdependence. Now, septal shudder is not same as septal bounce. It is flickering movement of the septum during diastole, and it is not a manifestation of exaggerated ventricular interdependence. It is rather a manifestation of variation in the tricuspid valve flow and mitral valve flow, and also in the electrical activity of left ventricle and the right ventricle, but it is also commonly seen in constrictive physiology. Now, this is again something which we need to focus. So this is what I was saying, to compare the pulmonary capillary wedge pressure and the LVEDP. If you see over here, during expiration, what is happening? The negative intrathoracic pressure is allowing the pulmonary capillary wedge pressure to fall, but thickened pericardium is not allowing the ventricular diastolic pressures to fall. So what is happening is there is negative the flow is variable during expiration and inspiration. In inspiration, I'm sorry, whatever I said was wrong. You see here, during inspiration, what happens is the negative intrathoracic pressure will cause significant fall in the pulmonary capillary wedge pressure, but the fall in LV diastolic pressure may not be as much, and therefore the gradient in inspiration between wedge and LVED will be lesser compared to during expiration. So if the gradient is more during expiration, filling will be more, and that is what we see as increased output of LV during expiration. Now this is what is square root sign or dependent plateau sign. And this is what I was saying as rapid filling wave. The cutoff is 7 millimeter of mercury to diagnose constrictive physiology. And if you superimpose this JVP on this, you will now understand why the JVP will have exaggerated Y descent and why it will continue to have X descent, which will be seen in these patients. And if you have not noticed till now, I have color coded this flow. So this green is the phase of exaggerated ventricular filling. Yellow is the diastasis, and orange is the one where there is some more filling which is happening. So now you can think why there is exaggerated filling and why there will be exaggerated Y wave, why there should be rapid filling wave in the left ventricle, and why these all should be characteristic of constrictive physiology. Now the same thing is seen in mitral valve propagation velocity. If you see, this again will increase during expiration because the flow across mitral valve will increase during expiration, and the reverse will happen during inspiration. Now this is systolic area index, and we all know systolic area index is RV area oblique LV area in inspiration divided by the same area in expiration, and this gives a better representation of the same. As you can see over here, since it is discordant during constrictive physiology, this systolic area index is going to be higher. It will be more than 1.1, while it will not be the same in the other one. Now, this is a common question which comes to our mind. If there are so many signs, which one is the most important sign? So like many other things in hemodynamics, and for that matter in our life and clinical practice, no single hemodynamic finding is diagnostic. As you can see over here, this is the spread of LVEDP minus RVEDP. And if you see, if you take a cutoff of 4 millimeter of mercury, then a lot of patients of constriction also will have this spread. Similarly, if you take RVEDP by RVESP more than 0.38, then again, it is not so dichotomous, but still, since these numbers give us a relative differentiated between constriction and restriction, we tend to take these numbers, but everything depends upon the company it keeps. So we have to see all the things in totality before making our diagnosis of constriction and restriction. And mind you, there can be overlaps at times which may be present in one patient or the other. So to summarize these findings, I mean, I'll start again from jugular venous pressure because that is quite important. So as you can see, it is elevated in both waveforms. There will be almost always there will be prominent Y descent. In restriction, variable Y descent because that will depend upon the myocardium, whether that will allow the myocardium to relax and take the blood. Kussmaul sign will be present in both the conditions. And as I said over here, hepatic vein flow reversal will be expiratory in pericardial constriction, while it will be inspiratory in restrictive cardiomyopathy. Now, if you look at these different echocardiographic signs, as I said, once you use more than one sign, your specificity increases more than 90%. So the message is, don't look at only one sign. Don't be dependent on septal bounds. Look at other things, because those are the things which will increase your specificity for the diagnosis. Now, coming to the hemodynamics, if we see, so this is the typical M pattern. The respiratory variation will be less than 3 millimeter mercury, and I have explained why it should be so. In RCM, since there is continuous transmission of pressure from intrathoracic to intracardiac, this variation will be there more than 3 millimeter of mercury. Right ventricular pressure, I've already highlighted. The peak generally is less than 50. This gap is less than 5, and RVEDP is more than 1/3 of the RV systolic pressure. Rapid filling wave, and this difference I have already said. Discordance and concordance we have already discussed, and systolic area index more than 1.1. Now, this exaggerated ventricular interdependence is also seen in cardiac tamponade, but we generally don't discuss these things together because tamponade is generally an acute physiology. Now, this also can explain why there should be pulsus paradoxus in all the cases of tamponade, because it is generally of severe nature, while in CCP, the exaggeration of ventricular interdependence is of not that degree. And therefore, only 1/3 patients of CCP will have pulsus paradoxus, and maybe the presence of pulsus paradoxus in pericardial constriction is a marker of severity of pericardial constriction. Again, like echo parameters, if we use multiple things, then our specificity is higher. A single parameter has very poor specificity other than LV-RV interdependence and systolic area index. But these two are nothing but a summation of whatever we have seen over here. So the bottom line is we have to look at ventricular interdependence, whether they are concordant or discordant. If they are discordant and they are exaggerated ventricular interdependence, it is likely to be constriction. In other cases, it is likely to be restriction. So now look at this pressure trace here. As has been highlighted, there is diastolic equalization. RV systolic pressure is less than 50 and RV ADP is more than 1/3 of RV systolic pressure. So what we are dealing with is constriction with reduced cardiac output. Now let's see if we were awake. I said interventricular septum is quite important. Now, what are the prerequisites for ventricular interdependence? So one, patient should be breathing. So it can happen only if the patient is breathing normally. So if the patient is on ventilator, it will be in the reverse direction. Are there any conditions without ventricular interdependence despite pericardial constriction? Like for example, in this case, there is obviously the pericardial constriction, but can there be a condition when there is no ventricular interdependence or the ventricles are moving concordantly? So the answer is, if there is large ventricular septal defect, then it will not happen because both the ventricles will work in the same fashion. There is no reason why there should be reduction in LV pressure during expiration and increase in the RV pressure during inspiration. So this patient actually had no septal bounce. There was no difference in the pressures because of VSD, but also whatever changes were happening were concordant, but there was preservation of this change in the capillary wedge and ED thing. And there was also change in the mitral inflow. So these things will keep on changing whether or not you have intact ventricular septum. The second prerequisite is the patient must have intact interventricular septum. What is the third? Third is, if there is any condition which will negate the change in respiratory variation in mitral and tricuspid inflow, will negate the effect on ventricular interdependence. When that will happen? In patients with large ASD, because if there is a large ASD, flow will be equal during inspiration and expiration. It is the same explanation which you give for widened fixed wrist plate, which will work here. So a large ASD patient is also less likely to have discordant ventricular pressure traces. I don't have one to show, but what I'm saying is based on echocardiographic analysis of one patient who had coexisting CCP with large ASD. So the take home message is cardiac hemodynamics is very fascinating, and understanding the basics of hemodynamics helps in appropriate interpretation of clinical, echocardiographic and catheterization findings in patients with pericardial constriction and restrictive cardiomyopathy. Now, suggested reading, this is one of the papers we have written, and since quite a few people have told that they found it useful, so I'm sharing that if you are interested in understanding hemodynamics, you might as well read this. But this paper is much, much better if you want to understand the complete analysis of how these things changes, and quite a bit of what I had in my presentation are from these two papers. Thank you so much for your patience hearing. Thank you.
Thank you so much, Dr. Saurabh, for very lucid, basic understanding of constrictive pericarditis physiology and the restrictive physiology. Starting from the basics is very, very important, because this is what is the easiest way to remember and answer and use these things in practical. So if we have any questions and comments from our colleagues, Dr. Sumod, Safal and Dr. Girish, we will be very happy to answer any additions or any particular questions they would like to ask or clarify. Yeah.
Yeah, Saurabh very nicely presented. Saurabh, I think another common question that is asked is about this occult kind of CCP and how to manifest the occult CCP that is present. So how much fluid and so can you just tell for the residents' sake how to?
When it is said occult, actually it works both ways. It can be when there is dehydration, then also it can be occult. In the cases when we are doing CAT study, we may not find all the signs. And then there is rapid infusion of 400 to 600 ml. Some books write 600 to 800 ml. And if it is a child, then 10 to 20 ml per kg over 15 to 20 minutes. Now, this is quite known thing. But there is something else which also causes occult pericardial constriction. If the patient is fluid overloaded, if there is too much of fluid in the system, then also you are likely to miss some of the findings. Specifically, the respiratory variation in mitral inflow is blunted if the patient is fluid overloaded. So if you suspect pericardial constriction and you are not getting respiratory variation in mitral inflow, try to do this repeat echo assessment after giving diuretic and reducing the fluid content of the patient.
Is there anything like transient constriction?
Transient constriction is an entity which is generally seen in the post-op setting. Some people also believe that it can happen in the setting of infective physiologies, in infective reasons of pericarditis. So some patients of bacterial pericarditis, we have seen that they present and we start thinking that we need to get pericardiectomy. But after a few weeks, we realize that it is not constricting as much. So possibly those are the ones where there is effusion plus constriction, which is combining and exaggerating the findings of constriction, and where we start thinking that this may be constrictive, but actually it is not so.
One question the PGs are asking is if we have a patient with suspected CCP, we are taking up of echo. Can you tell in stepwise way how you are going to do the echo?
Okay. So first of all, we need to understand, we have to first define that the patient is in heart failure. So we start from the systemic veins. You look at the IVC. look at the diameter, look at its respiratory variation, focus on the hepatic vein, look at what is happening there. And once you have made up your mind that you are dealing with a patient who is having a pattern which may be consistent with constriction or restriction, then you go ahead and elicit other things, because these are the things which are easiest to do. You just put a probe on your subcostal thing and you look at the IVC and then move ahead. So first thing is IVC hepatic vein. Then you go to mitral, transmitral flow, because those are probably the most sensitive and easy to do. And they are more objective since you have E wave and the A wave, and you can just measure and see whether they are showing abnormal patterns. Whenever we are doing mitral inflow velocity, we should always change the velocities or the speed of the echo so that we are seeing more mitral inflow beats in one screen, so that our appreciation of expiration and inspiration are becoming better. Second thing is, if we have a facility of attaching respirometer, then that helps in this understanding what is happening during expiration and inspiration. Even if that is not there, then we should assume wherever mitral flow is reducing is inspiration and the reverse is expiration. After this, our focus should be shifted on the septum. In parasternal long axis view, we can do M mode and look at whether there is a septal bounce. I think that's how I will approach a case with suspected constriction. Regarding pericardial thickness, that remains subjective. I don't go much about pericardial thickness on echo because that's not reliable. But if you have to do, then reduce the gains significantly so that your cardiac chambers are almost black. And if you are seeing something hyperrefractile on the peripheries, then you are dealing with thickened or maybe calcified pericardium.
Then again, septal bounce and septal notch. So, is there any difference, and the different modalities of echo in which it is seen? For example, M mode, 2D.
Yeah, septal bounce is a respirophasic variation. So it will change with the respiration of the patient. So it occurs with a lesser frequency. So in a minute, it will happen 15 to 18 times, depending upon the respiration of the patient. So we can do on 2D, we can do on short axis of LV. But if we want to see the septal shudder, it is a finer movement which happens many times during one beat. So it happens almost like 200 times in 1 minute. So you need to have a high frequency modality, something like M mode, to pick septal shudder or septal notch.
Will it correlate with the dip pattern of ventricle in that is the septal notch?
Septal notch has not been shown to correlate with the hemodynamic changes. It seems to be, it's like something like that. The heart is encased by a bag which is thickened. Now both the ventricles are pushing each other to gain more preload. So they will keep adjusting with each other. So I think the septum keeps moving till it adjusts. So that is what is seen in septal shudder.
Yeah, Dr. Rohit from Raebareli, he wanted to know why the PA pressures are higher than PA systolic is more than 50 in restrictive physiology.
So when we talk about restrictive physiology, the myocardial abnormality will increase the LV and diastolic pressures. So there will be changes in the vasculature. So there is reactive vasoconstriction that will increase the pulmonary artery diastolic pressure. While in constriction, it is a passive transmission of all the pressures. So restriction is more like what we see in, say, mitral stenosis, where there is increase in LA pressure that is causing increase in the PA diastolic and other pressures. So there are two things which are happening. One is the abnormality of the filling, and second, there are changes in the pulmonary vasculature. In constriction, whatever is happening, the heart is working like a conduit, and the conduit is changing with respiration. So there is only one mechanism, which is the back pressure. So there is limited increase in the RV systolic pressure, and that will reflect onto limited increase in the PA systolic pressure.
So in what percentage of cases roughly do you have to move beyond an echo for in what percentage of
Diagnosis.
cases you have to go beyond an echo for a diagnosis with reasonable surety?
I think to confirm pericardial constriction, I think more than 75-80% patients we can confirm by echo, but there will still be 15 to 20% cases where doubt remains. And echo, we have to spend time if we want to be sure about constrictive physiology. Many a times it happens that we discard echo findings because we have not done it well. So if it is done well, then I think 75 to 80% patients will, echo will be sufficient. Other than confirming the thickness of pericardium, which anyway, we need other modality if we want to do.
Any new data regarding the use of steroids, especially in tuberculosis?
Sir, please repeat the question.
Any new data regarding the use of steroids in tubercular pericardial effusion for the prevention of maybe constriction?
No, I'm not sure of any good data which shows this way or the other way. No, I'm not sure about that. We in general tend to give steroid. Whether it is beneficial, I'm not certain.
Tissue Doppler, again, sort of this endless paradoxes, and would you like to make a comment on the use of tissue Doppler in differentiation between the two conditions?
So tissue Doppler is basically a modality which picks the myocardial velocities. Now, as soon as we say this, it becomes apparent that it is likely to be more abnormal in restrictive physiology compared to constrictive physiology. Now, when we say this, what we are also saying is the myocardial velocities will be different in these two conditions. Now, I did not go into that detail because I was trying to focus on the hemodynamic aspect of it. But there are changes which will, if you allow me to share my screen, I can show from my other presentation where TDI can show that. So I'll just share my screen. And so my screen is visible, I guess.
Yeah.
So one thing is that if the myocardial velocities are reduced, then we are more likely to have restrictive physiology. If it is normal, then constriction is more likely. Then we have to see whether the medial annulus and the lateral annulus are similar or there is a difference in their velocities compared to the normal standards. Now, annulus reversus is lateral E dash is less than the medial E dash. And annulus paradoxus is E upon E dash keeps improving as the medial annular E dash keeps increasing. So these are the things which we will need to clarify further, whether or not the patient of constriction also has myocardial involvement. Now, since the lateral annulus is towards the pericardium, it is likely to be adhered to the pericardium. So the lateral annulus is likely to be moving lesser compared to the medial annulus. And that is what explains this difference in the condition.
So any experience with post-surgery constriction, cardiac MRI predicting some element of reversibility?
No, reversibility of
the constriction, the transient constriction that we were talking about.
No, I'm
in
not,
some series. Yeah.
I have not read in great detail about transient constriction, but if a patient develops disproportionate heart failure after surgery and it doesn't resolve beyond say 2 weeks, then we should start thinking. It's actually counterintuitive. post-surgical pericardial constriction is counterintuitive because during surgery, they tend to remove pericardium, but still it happens. So why it happens? I mean, it's a bit of a question which needs more exploration. But later on, we know that it happens, and people are relieved once they undergo repeat surgery. That much is for sure. I mean, there are some questions I can also see if I can answer that. So in apnea, septal bounce will be present. Septal bounce should not be there. It may still be mild variation may still be there because blood is moving. So if you do catheterization in a patient on ventilator, then it would be the reverse. And that has been shown. There are few papers which shows that. How to differentiate in COPD, RV failure, and CCP. I think hemodynamics, I mean, it's a vast topic. We can keep discussing about it, but I would not like to spend 2 minutes because it's a question which will take more than that. And probably I'm not ready to explain all that right now. So I'll skip that.
Okay. Thank you, Dr. Saurabh, for a very lucid, very basic presentation, which was a great revision for many of us and something which was really thought-provoking for all our fellows and residents. As you were discussing, more than 250 residents are online at present now. And I would just like to summarize 3 things, because the best application and absorption of this particular knowledge would be that you go and read these 2 articles today. So this is a terrific article from 2018, Jack, which was differentiation, hemodynamic differentiation between constriction and restriction. And to complement that, one of the articles that Dr. Saurabh has published in Indian Heart Journal in 2015. And also I recommend a good read from Postgraduate Cardiology, which was a CSI book, and that is also summarizing the constriction and restrictive physiology very, very well. In case you have any questions and comments and any clarifications you want, please feel free to write to me. I'll post all these articles in your group so that you can read them right away. And next week, we'll again be presenting, coming up with a different session. You have any suggestions, please write to us. I thank all my colleagues, Dr. Sumod, Dr. Grish, and Dr. Safal for joining us. Thank you, Saurabh, definitely to you for such a terrific presentation. And thank you, Intas, for providing us this academic platform. So have a great evening and great weekend, and we'll catch up next Thursday, same time with another session. Thank you so much.
Yeah. Thank you, sir, and good night.